I'm Siwen Hu Lisgovan. I'm a medical oncologist at UCLA Medical Center, and my specialty is melanoma and immunotherapy-based treatments. So there are two trials at this ASCO. Both are phase 1 at early stage development that has shown very nice signal that the combination may be promising in treating solid tumors. One of them is a combination of anti-CD137 antibody, and it's also called 41BB agonist. So this is a receptor on the T cell, and when you activate the CD137 receptor, then you activate the T cell. And combining this with the anti-PD-1 therapy, anti-PD-1 antibody pembrolizumab. And 23 patients were treated, and the drug was very tolerable. There was no dose-limiting toxicity observed, and 6 patients out of the 23 had a clinical response, either complete response or partial response. So that was a very promising combination. And the other one is combination of anti-OX40 was a anti-PD-L1 antibody. So this combination has also shown a very nice safety profile with no dose-limiting toxicity and good activities. So this is another way of combining effective immunotherapy treatments. And the third combination would be combining target therapy with checkpoint inhibitors. So in melanoma, we know that for BRAF mutant melanoma, we can use BRAF and MEK inhibitors to treat this tumor, and we can induce a very high response rate. But a lot of patients actually relapse after 1 or 2 years. And on the other hand, with immunotherapy, we know we can induce a pretty durable response, but when in a very small percentage of patients. Now with the combination of EP plus Nivo, that the response rate has increased. But we hypothesize that if we combine targeted therapy with immunotherapy, maybe we can increase the response even further with a durable response. And the rationale is not just combining 2 effective treatments. And there were preclinical studies showing that BRAF and MEK inhibitors actually can help to sensitize the immune system and make the immune therapy work better. It can increase the antigen presentation, increase the T cell infiltration into the tumors, and maybe increase the function of the T cells. So, so at this ASCO, there was a presentation of combination of dabrafenib, which is a BRAF inhibitor, with MEK inhibitor, tremelimumab, and pembrolizumab that has shown a very good safety profile and efficacy. Only very small number of patients were treated, so it's early to say. It's hard to make any conclusions, but these are very promising combination strategies. And lastly, there is a trial combining MEK inhibitor cobimetinib with anti-PD-L1 antibody atezolizumab in colon cancer patients. Now that was a very novel combination. So we know that in colon cancer patients who have a microsatellite instability, we have seen a very nice response to anti-PD-1 therapies. 70% of patients can respond to this therapy. But for the patients who don't have this microsatellite instability, actually 0% of patients responded to checkpoint inhibitors. This was results released at the last ASCO. So this year, with this trial, majority of the patients in this trial actually have colon cancer without microsatellite instability, and by adding the MAC inhibitor, it can actually induce a 17% of response rate. So that definitely is a very nice signal, and is something worth further pursuing. So pembrolizumab is one of the anti-PD-1 antibodies, one of the first ones being developed. So it was approved for treatment of advanced melanoma and non-small cell lung cancer. And there are a lot of clinical development in other cancer types, in head and neck cancer, in Hodgkin lymphoma, and also combination therapies with different agents. Several trials that I have mentioned is a combination with pembrolizumab. So just as a class, anti-PD-1 therapy has shown activity in a increasing list of tumor types. And the unique part about anti-PD-1 therapy is it actually work at the last step of T cell activation. When the T cells, activated T cells, go to the tumor to kill the tumor cells, and the tumor cell sense the danger and express the PD-L1 on their surface and stop the T cell from attacking. So in theory, if we are going to do immunotherapy with a T cell as the effector cell, then we always have the concern that when the T cell, no matter how you activate them, when they go to the tumor, they would encounter this last step of a checkpoint inhibition. So there is a school of thought that when we develop combination therapies, anti-PD-1, PD-L1 antibody should be the backbone of this combination.